All right, everyone. Welcome to Essentials of Hematology. Now, before anyone panics a little inside, yes, I know the word hematology sometimes makes people immediately think of complicated differentials, mysterious cells, and stains that seem to behave differently depending on the phase of the moon. But here's the good news. This course is not about memorizing endless cell names or turning you into a hematologist overnight. This course is about, again, understanding patterns, and histotechnologists are already very good at pattern recognition. You already understand tissue architecture, you already think microscopically, you already ask, what am I looking at and why does it look that way? We're just applying that same mindset to a tissue that happens to flow instead of sit still. Over the next several weeks, we're going to connect bone marrow, circulating blood, and disease processes into one continuous biological story. Because blood is not random, it follows rules. And once you understand those rules, hematology starts to feel surprisingly logical. Let me start by saying something important. Hematology often feels intimidating at first. And honestly, that's normal. Unlike solid tissue histology, where structure stays relatively stable, blood is dynamic. Cells are constantly developing, maturing, circulating, and being removed. You're essentially looking at a moving snapshot of physiology. But here's the key idea for this course. Hematology follows biological logic. Cells develop in predictable sequences. They mature in recognizable ways. And disease usually looks like an interruption of normal development. So instead of memorizing isolated facts, we're going to focus on understanding developmental pathways. If you understand where a cell comes from, you can usually understand why it looks abnormal, why it appears in circulation, and what the body is trying to respond to. And this part is especially important for histotechnologists. Blood is not separate from histology. It is tissue. It's connective tissue, just in liquid form. So everything you already know about cellular adaptation, injury, and response still applies. We're just observing it through a different window. And honestly, once students realize that, hematology usually clicks. Now you might be wondering, why does hematology matter specifically for histotechnologists? Because you're not training to run a hematology lab. But here's the reality of modern pathology. Blood tells stories about the entire body. Many systemic diseases leave hematologic clues long before structural tissue changes become obvious. And from a surgical pathology perspective, you encounter hematology more than you might think. Bone marrow biopsies are incredibly common specimens, and those specimens require histotechnologists who understand what normal marrow should look like, how cellularity changes, and why morphology matters diagnostically. When you're embedding, cutting, or staining marrow cores, you're not just processing tissue, you're preserving diagnostic information about an entire hematopoietic system. Also, many non-hematologic diseases show up directly in blood. Inflammation, infection, chronic disease, and systemic stress responses. So when we study hematology here, the goal isn't to make you specialists in blood disorders. The goal is to make you better diagnosticians. Because once you understand how blood reflects systemic physiology, you start seeing connections everywhere between organs, disease processes, and microscopic findings. And that's where histotechnology moves from technical skill to clinical insight. All right, let's talk about where we're going this semester because hematology makes a lot more sense when you understand the path we're taking. This course is intentionally built like a diagnostic workflow. We are not jumping straight into disease. Instead, we move in the same order your brain should work at the microscope. First, normal development, because you cannot recognize abnormal if you don't know what normal is supposed to look like. Then, normal morphology. What do healthy cells actually look like? Not textbook perfect drawings, real morphology. Next, functional changes. What happens when the body is stressed, inflamed, infected, or compensating? Only after that do we move into disease processes. And finally, the goal, diagnostic reasoning. In other words, normal leads to abnormal, which leads to interpretation. That sequence is everything in hematology. If you ever feel lost during the semester, come back to this roadmap. Ask yourself, am I looking at development, response, or disease? Most confusion disappears once you place a finding somewhere along that pathway. So what exactly is hematology? At its core, hematology is the study of blood-forming tissues and circulating cells. But it's really about understanding a system that connects the entire body. We're studying blood cells, bone marrow, hematopoietic tissues, and coagulation systems, which means hematology sits right at the intersection of histology, physiology, and pathology. Now notice the focus areas listed here. We're not just naming cells, we're asking, how are cells produced? What structures do they develop? What functions do they serve? And what happens when that process goes wrong? This should feel familiar to you as histotechnologists. When you look at tissue sections, you already ask, what is this structure doing and why does it look this way? Hematology asks the exact same question, just at the cellular circulation level. And here's an important mindset shift. Blood isn't static anatomy. It's active biology in motion. Every smear is essentially a real-time physiologic report from the body. You're not just seeing cells, you're seeing responses. One of the biggest differences between hematology and traditional histology is this. Blood is constantly changing. Cells are continuously being produced in the bone marrow, released into circulation, responding to physiologic demands, and eventually removed and recycled. Nothing in blood stays the same for long. Red cells live about 120 days. Neutrophils may only circulate for hours before entering tissues. Platelets are constantly turning over. So when you examine blood, you are looking at a snapshot of an ongoing process, not a fixed structure. And this is why blood is often the first tissue to show disease. If the body is stressed, infected, inflamed, hypoxic, or failing somewhere else, hematopoiesis adjusts almost immediately. Bone marrow responds, production changes, cell proportions shift, and morphology starts telling a story. In many ways, blood acts like the body's early warning system. And from a histotechnology perspective, this matters because systemic disease frequently explains what you later see in solid tissues. So when we say blood reflects what's happening throughout the body, that's not poetic language. It's literally physiology made visible under the microscope. Now we shift perspective a little. We just talked about blood as something dynamic and constantly changing, but biologically speaking, blood is actually classified as a specialized connective tissue. And yes, students always pause here and go, wait, connective tissue? But it makes sense when you think about the definition. Connective tissues have cells, an extracellular matrix, and a role in supporting or connecting body systems. In blood, the matrix is plasma, and instead of cells being anchored in place like cartilage or bone, they're suspended and mobile. That mobility is what makes blood unique. Unlike most tissues, cells don't stay fixed. They circulate continuously. They're constantly being replaced. From a laboratory perspective, this matters a lot because when we examine blood, we're essentially looking at a moving snapshot of systemic physiology. What we see on a smear reflects bone marrow activity, immune response, oxygen demand, and even systemic stress. So blood isn't just traveling through the body, it's reporting on it. Now let's talk about why blood matters functionally. Blood has several major roles, and every one of them shows up in laboratory testing. First, oxygen transport. Red blood cells carry oxygen using hemoglobin, delivering it to tissues that depend on aerobic metabolism. When this system fails, tissues suffer quickly, which is why anemia shows clinical symptoms so fast. Second, immune defense. White blood cells patrol constantly, identifying pathogens and abnormal cells. Changes in leukocyte number or morphology often give us early clues about infection, inflammation, or malignancy. Third, hemostasis. Platelets and clotting proteins prevent blood loss after injury. Too little activity leads to bleeding disorders. Too much leads to thrombosis. The lab helps clinicians find that balance. Then we have nutrient delivery and waste removal. Blood acts like the body's transportation highway, delivering glucose, hormones, and electrolytes while carrying away carbon dioxide and metabolic waste. And finally, regulation, pH balance, and temperature control and fluid equilibrium. So when we analyze blood, we're not just evaluating cells, we're evaluating homeostasis itself. Now let's break blood down into its actual components, because this becomes foundational for everything we do in hematology. Blood is divided into two major parts. Plasma, which is about 55%. Now this is mostly water, but it's far from empty fluid. Plasma contains proteins like albumin and globulins, clotting factors, electrolytes, nutrients, hormones, and waste products. Think of plasma as the transport medium that allows communication between organ systems. Then there's formed elements, and this is about 45%. These are the cellular components we evaluate microscopically. They include erythrocytes, or red blood cells, that are responsible for oxygen transport. Their shape, size, and staining characteristics tell us a lot about systemic health. Leukocytes, or white blood cells, these are the immune responders, right? So differential counts help us understand infection, inflammation, and hematologic disease. And then platelets. These cell fragments are essential for clot formation and vascular repair. When we centrifuge blood and see those layers separate, we're literally visualizing physiology organized by density and function. And this is where hematology becomes very visual, because every disease process tends to alter one of these components first. All right, now let's talk about something histotechnologists actually appreciate more than most people, which is cell turnover. Because if there's one thing we understand deeply in histology, it's this. Tissues are never static. They're constantly renewing, repairing, and quietly replacing themselves behind the scenes. Blood is basically the overachiever of turnover. Let's look at the timelines. Red blood cells live about 120 days. That sounds long until you realize your body is making roughly 2 million new red blood cells every second just to keep up. No pressure, bone marrow, no pressure. Neutrophils are the disposable emergency responders. They live hours to days, depending on whether they get called into action. Once they leave circulation and enter tissue during inflammation, their lifespan drops dramatically. They show up fast, do their job aggressively, and burn out quickly. The healthcare workers of the cellular world. Platelets last about 7 to 10 days, constantly cycling to maintain clotting readiness. So what's the big takeaway here? Blood cannot sit still. If production pauses even briefly, numbers fall quickly. There's no long-term storage system. From a histotechnology perspective, this matters because changes we see in blood or marrow often reflect very recent physiologic events. Blood morphology is basically a real-time status update from the body. And that's why continuous production isn't optional. It's survival. Now let's build on that idea. Blood cells are constantly aging, performing their function, and then being removed. There is no retirement plan for blood cells. No pension, no vacation phase. Once they're done, they're cleared, mainly by the spleen and the liver. So the body has to maintain a perfect balance. Replacement must equal destruction. If destruction exceeds production, then cytopenias develop. If production exceeds regulation, then abnormal proliferation or immature cells appear. This balance is what we call homeostasis. And honestly, hematology is one of the clearest demonstrations of homeostasis anywhere in the body. Here's where this becomes very histotech relevant. Bone marrow activity changes rapidly in response to stress. So infection, hypoxia, bleeding, inflammation, or systemic disease. That means marrow specimens and peripheral smears often show shifts before structural organ pathology becomes obvious. In other words, blood doesn't just participate in disease, it announces disease. It's like the body's early warning notification system, except instead of a phone alert, you get a morphologic clue under the microscope. Now we arrive at one of the central concepts of hematology, hematopoiesis. Fancy word, simple idea. Hematopoiesis just means formation of blood cells. In adults, this happens primarily in the bone marrow, specifically red marrow located in axial skeletal sites like the pelvis, vertebrae, the sternum, ribs, and proximal long bones. And unlike many tissues you've studied, hematopoiesis is not random growth. It's an incredibly regulated developmental hierarchy. Everything starts with hemopoietic stem cells, the ultimate multipotent overachievers. These cells can self-renew and differentiate into every circulating blood cell lineage. So erythrocytes, leukocytes, and platelets. Think of bone marrow as less of a factory and more of a training academy. Cells enter as undecided recruits and leave with very specific careers: oxygen transport, immune defense, or clot formation. From a histotechnology standpoint, marrow is fascinating because you're not just looking at one tissue, you're looking at multiple stages of cellular development simultaneously. It's one of the few places in the body where development itself is visible under the microscope. And that's why marrow evaluation requires pattern recognition rather than memorizing isolated cells. You're assessing relationships, maturity progression, lineage balance, and whether production matches physiologic need. When hematopoiesis runs smoothly, peripheral blood looks boring, which in pathology is usually a good sign. When regulation breaks down, morphology starts telling a story. And as we move forward, we're going to learn how to read that story. Now we arrive at what I like to call the ultimate origin story of blood. Everything we see on a peripheral smear, every leukocyte differential, every platelet clump you've ever grumbled about, all traces back to hematopoietic stem cells, or HSCs. These cells live primarily in the bone marrow microenvironment, and they are incredibly powerful despite being extremely rare. You can scan an entire marrow and only find a tiny population, but they are responsible for maintaining the entire circulating blood system for a lifetime. They have two superpowers. First, self-renewal. They can divide and make another identical stem cell. This is critical because if stem cells only differentiated, we would literally run out of blood production capacity. Second, multipotential differentiation, meaning one cell has the ability to become any blood cell lineage, so red blood cells, white cells, or platelets, the whole crew. From a histotechnology perspective, this matters because when hematopoiesis goes wrong, the problem often starts here. Many marrow disorders aren't just too many cells or too few cells. They are problems of regulation at the stem cell level. And here's the wild part. One properly functioning stem cell population can maintain blood production for decades. That's efficiency most lab staffing schedules could only dream of. So once stem cells commit to becoming something more specific, we start seeing organization. And hematology loves organization. All blood development branches into two primary lineages, the myeloid lineage and the lymphoid lineage. Think of this like choosing a career path early in training. Once a progenitor cell commits, its future options narrow. The myeloid pathway produces most of the cells we routinely identify morphologically, the ones histotechnologists and morphologists spend a lot of time staring at under oil immersion. The lymphoid pathway heads toward adaptive immune cells, lymphocytes that specialize in immune recognition and response. Why do we care about this distinction? Because disease often follows lineage patterns. If an abnormal population expands, one of the first diagnostic questions becomes which lineage is involved. When you're looking at marrow biopsies or correlating smear findings, recognizing lineage patterns helps explain why certain cell types increase together while others stay normal. In other words, hematology isn't random chaos. It's a structured developmental tree. Now let's zoom in on the myeloid lineage, because this is where histotechnology and morphology really start to shine. The myeloid pathway produces erythrocytes, which are your oxygen delivery specialists, produces neutrophils, the first responders of inflammation. There's eosinophils, which are allergy and parasite specialists. Basophils, so they're small in number but big in inflammatory signaling. Then monocytes, circulating precursors that become macrophages in tissue. And platelets, technically cell fragments, but absolutely essential for hemostasis, I'm sorry. One progenitor pathway gives rise to an incredibly diverse workforce. And here's a key histology connection. Although these cells look completely different when mature, early precursors in bone marrow can look surprisingly similar. Differentiation is gradual. Morphology evolves step by step. This is why marrow interpretation requires pattern recognition rather than memorizing isolated appearances. You're watching development in motion. Also worth appreciating, megakaryocytes, the platelet producers, are enormous compared to everything else in marrow. Nature basically saying we need thousands of platelets, let's just build one giant factory cell. Efficiency again. Understanding this lineage helps explain reactive processes too. Infection? Expect neutrophil expansion. Chronic inflammation? Monocyte/macrophage involvement increases. Blood loss? Erythroid production ramps up. The marrow is constantly adjusting production based on physiologic demand. It's less like a static tissue and more like a highly responsive manufacturing system. Now we switch branches on our hematopoietic family tree. Up to this point, we've been living mostly in the myeloid world, which gives us a lot of the cells histotechnologists see regularly in inflammation and tissue response. Now we move into the lymphoid lineage, which is essentially the immune system's strategic planning department. From the lymphoid progenitor cell, we get three major players: B lymphocytes, T lymphocytes, and natural killer or NK cells. Think of these less as first responders and more as specialized intelligence units. B cells are responsible for antibody production. Once activated, they differentiate into plasma cells, which you will absolutely recognize histologically: eccentric nucleus, clock face chromatin, and that perinuclear HOF that screams protein factory. When you see plasma cells in tissue, your brain should immediately think chronic inflammation, immune activation, or plasma cell disorders. Then there's T cells. T cells handle cell-mediated immunity. They don't make antibodies, they directly regulate or destroy cells. They are critical in viral infections, tumor surveillance, and autoimmune disease. Histologically, you usually don't identify them individually, but their patterns of infiltration tell the story. NK cells? Natural killer cells are basically immune system bouncers. They recognize stressed or abnormal cells without needing prior sensitization. No introductions required. They just remove suspicious cells. Histotech takeaway: when you see dense lymphocytic infiltrates, you are often looking at lymphoid lineage activity responding to something systemic, infectious, or neoplastic. Blood development is already starting to connect directly to tissue interpretation.
Okay.
This slide looks intimidating at first glance, and honestly, that's fair. This is the entire hematopoietic roadmap, the biological version of a subway map where every line eventually connects somewhere important. But here's the key. You are not memorizing every stop. You are learning the logic of movement. Everything begins with the hematopoietic stem cell in the bone marrow. From there, cells commit to either myeloid or lymphoid pathways. They undergo stage maturation, morphology gradually changes, mature cells enter the blood, some migrate into tissues and gain new identities. Why this matters for histotechnologists? Well, because disease often represents arrested development, overproduction, abnormal maturation, or cells appearing where they shouldn't be. When pathologists say things like left shift, blast population, reactive lymphocytosis, they are referencing disruptions somewhere along this pathway. So instead of memorizing names, ask, where did development go wrong? That question is diagnostic gold. A fun reality check? Bone marrow is basically running a non-stop manufacturing plant producing millions of cells every second, and somehow maintaining quality control better than most group projects. Now here's something students often underestimate. Hematopoiesis is not just about cells. It's about environment. Bone marrow is not empty space filled with developing cells. It's a highly regulated ecosystem. Think of bone marrow like a carefully engineered greenhouse. Cells grow successfully because the environment provides structural support through stromal cells and extracellular matrix, physically anchoring development cells. They aren't floating randomly, so location influences development. And there's growth factors. Chemical signals tell cells divide, mature, pause, or undergo apoptosis. Without these signals, development fails. Then cellular signaling. Neighboring cells constantly communicate. Development depends on interaction, not isolation. A nutritional environment. Oxygen levels, nutrients, and vascular proximity all influence differentiation. Even slight changes can shift production patterns. Histotechnology connection, and this is a big one. When bone marrow architecture changes, fibrosis, infiltration, leukemia, metastatic disease, the environment collapses. And when the environment changes, cell production changes. So abnormal blood counts often reflect a microenvironment problem, not just a cell problem. So just remember, hematopoiesis is not just biology, it's ecology. Healthy blood requires the right cells and the right neighborhood. Now we're going to rewind developmentally for a minute because hematopoiesis does not start where it ends up. Blood formation actually migrates through the body during fetal development, almost like a traveling laboratory setting up shop wherever conditions are best. Let's walk through the timeline. First stop, the yolk sac. Early in embryonic life, the yolk sac produces primitive blood cells. These early erythrocytes are mainly focused on oxygen delivery while organs are still forming. Think of this as the starter kit version of hematopoiesis. Functional but temporary. Next, hematopoiesis shifts to the liver, which becomes the primary blood-forming organ during mid-gestion. The liver provides a supportive stromal environment and growth factors that allow more advanced cell development. The spleen and thymus also contribute during this period. The spleen assists with hematopoietic activity. The thymus becomes critical for T cell maturation, which foreshadows immune system development. Finally, as the skeletal system matures, hematopoiesis transitions into the bone marrow, where it will remain for the rest of life. Histotechnology connection. When we see extramedullary hematopoiesis in adults, like hematopoietic cells appearing in liver or spleen biopsies, it's not random. The body is essentially reverting to its fetal backup plan. And yes, that absolutely shows up on slides. Once we reach adulthood, hematopoiesis becomes much more centralized and efficient. Instead of occurring everywhere, active blood formation is restricted to specific bones containing red marrow. Primary adult hematopoietic sites include the pelvis, which is the workhorse location, the sternum, vertebrae, ribs, and proximal femur and humerus. These areas contain trabecular bone spaces filled with active marrow capable of continuous blood production. Why these bones? Because they maintain rich vascular supply and supportive stromal niches that allow stem cells to survive, divide, and differentiate properly. Lab and clinical relevance. This is exactly why bone marrow biopsies are typically taken from the posterior iliac crest. Easy access, high cellularity, and representative hematopoiesis. From a histotech perspective, when you embed and section marrow cores, you are literally looking at the central manufacturing site of the hematologic system. No pressure, just the entire blood system on one slide. Now let's talk about something you will absolutely recognize microscopically, the difference between red marrow and yellow marrow. Red marrow is where active hematopoiesis occurs. It is highly cellular and packed with developing precursors, erythroid cells, myeloid cells, megakaryocytes, and stromal elements. Under the microscope, red marrow looks busy, nuclei everywhere, varying maturation stages, organized chaos. In contrast, yellow marrow is dominated by adipocytes. Its primary role is fat storage, but here's the important part. It is not permanently inactive. Under physiologic stress, like severe anemia, hemorrhage, or marrow failure, yellow marrow can revert back to hematopoietic activity. On slides, yellow marrow looks like large clear adipocyte spaces, sparse hematopoietic cells. Red marrow will see dense cellularity with mixed maturation stages. A quick rule students love: if you see more fat than cells, think yellow marrow. If you see controlled cellular chaos, think red marrow. As a clinical insight, a shift towards fatty marrow can occur with aging, chronic disease, or marrow suppression, while reconversion suggests increased hematopoietic demand. So marrow composition actually tells a physiologic story, and histotechnologists are often the first people to see that story unfold. All right, now we shift from what cells become to who's actually running the show. Hematopoiesis is not random cell production. The bone marrow is not just sitting there making blood cells because it feels productive that day. It is tightly regulated by signaling molecules that constantly monitor what the body needs. Think of bone marrow as a high efficiency manufacturing facility operating on real time demand. Production is controlled primarily by cytokines, growth factors, oxygen demand, and immune signaling. These signals either stimulate or suppress production depending on physiologic conditions. At the top of this slide, you'll see stimulatory growth factors like erythropoietin or EPO, GCSF, GM-CSF, or thrombopoietin, TPO, interleukins, stem cell factor, or SCF. These essentially tell progenitor cells, we need more workers, start dividing. But equally important are inhibitory cytokines, which prevent uncontrolled proliferation. Because uncontrolled hematopoiesis is not productivity, that's leukemia. From a histotechnology perspective, this regulation explains why marrow cellularity changes dramatically between patients. Infection, we'd see hypercellular marrow. Chronic disease, we'd see suppressed erythropoiesis. Chemotherapy, we'd see marrow shutdown. So when you look at a marrow biopsy, you're really seeing the outcome of signaling biology, not just cell morphology. Key takeaway, The body continuously adjusts blood cell production minute to minute based on physiologic need. Now let's walk through one of the cleanest and most clinically important feedback loops in hematology: oxygen regulation via erythropoietin, or EPO. Here's the sequence. When oxygen levels drop, meaning tissues are not getting enough oxygen, the kidneys detect hypoxia. Yes, the kidneys are basically oxygen sensors. In response, they release erythropoietin, a hormone that travels through the bloodstream to the bone marrow. EPO tells erythroid progenitors we need more red blood cells immediately. The marrow responds by accelerating erythropoiesis, increasing red blood cell production, and restoring oxygen delivery. Once oxygen levels normalize, EPO production decreases. Negative feedback, elegant, efficient, very biology approved. From a histotech standpoint, this explains several morphologic findings you'll encounter. Chronic hypoxia, so we'd see erythroid hyperplasia in the marrow. For kidney disease, we'd see decreased EPO or an anemia. And then high altitude adaptation would be increased red blood cell production. And clinically, this is why synthetic EPO is used in patients with chronic kidney disease. Important concept here: structure responds to physiology. What you see on the slide under the microscope is often the downstream effect of systemic signaling. So when you see increased erythroid precursors, your brain should immediately ask, what physiologic stress is driving this? That's histotechnologist thinking. Now we zoom into something histotechnologists live and breathe: cell maturation. Every blood cell follows a predictable developmental pathway from immature precursor to fully functional mature cell, and maturation follows consistent morphologic rules. As cells mature, you'll notice three major trends. They go from immature to mature, which means early cells are focused on growth and division. Mature cells are focused on function. We'd see large nucleus that goes to condensed nucleus. Immature cells have large nuclei because they are transcriptionally active. Lots of DNA activity, lots of protein production. As maturation progresses, chromatin condenses, the nuclear size decreases, and eventually, in erythrocytes, the nucleus disappears entirely. Yes, red cells commit the ultimate career move. They fire their nucleus. And the third is basophilic cytoplasm into functional specialization. Early precursors stain strongly basophilic due to abundant ribosomes. As specialization occurs, cytoplasmic granules develop, hemoglobin accumulates, and functional machinery replaces growth machinery. For example, neutrophils develop segmented nuclei and granules for phagocytosis. Red blood cells accumulate hemoglobin for oxygen transport. From a diagnostic standpoint, maturation patterns are everything. Normal maturation equals orderly progression across stages. Disordered maturation, that's where pathology lives. Myelodysplastic syndromes, leukemias, marrow stress responses. So when you're reviewing a smear or marrow section, you're not just identifying cells, you're assessing whether maturation is appropriate, accelerated, or arrested. And honestly, this slide is one of the most important mental frameworks in hematopathology. Disease, again, often reveals itself as a disruption of normal maturation sequence. This slide is where everything we just learned suddenly becomes very real clinically. Hematopoiesis is not just academic biology. It is the roadmap that explains why disease looks the way it does under the microscope. Most hematologic disorders fall into one of four big categories: overproduction, so too many cells being made, think polycythemia or leukocytosis; underproduction, so the marrow failure or suppression, think anaplastic anemia, chemotherapy effects, or nutritional deficiencies. Then there's arrested maturation, where cells start developing but never finish. Classic examples of this would be acute leukemias, where blasts accumulate, And lastly, abnormal differentiation. This is where cells mature incorrectly. They may look almost normal but function poorly. From a histotechnology perspective, this matters because morphology reflects biology. Cells don't randomly look abnormal. They are showing us where development went wrong. If you understand normal development, abnormal findings stop being memorization and start becoming logical. And honestly, that's when hematology becomes fun, when the smear starts telling a story instead of just staring back at you. This is one of my favorite conceptual comparisons because it helps students instantly understand what they're looking at. Think of bone marrow as the training academy and peripheral blood as the deployed workforce. Okay? In the bone marrow, you'd expect to see cells at every developmental stage. So immature precursors, active proliferation, and differentiation. It's busy, crowded, slightly chaotic, like orientation week for new employees. Peripheral blood, however, should contain mature functional cells, cells that have graduated and are now doing their jobs. So when immature cells show up in circulation, like blasts, early precursors, or nucleated red blood cells, that's a red flag. It often means one of three things. The marrow is stressed and pushing cells out early. The marrow architecture is disrupted, or malignant processes are overriding normal control. As histotechnologists and laboratory professionals, recognizing that mismatch between expected location and developmental stage is a major diagnostic clue. Location matters just as much as morphology. Now we transition into where you come in as laboratory professionals. The peripheral blood smear is one of the most powerful and honestly underrated diagnostic tools in medicine. When we evaluate a smear, we are not just looking at cells casually. We are systematically assessing cell size, so are red blood cells uniform, microcytic, macrocytic, the shape, so the poikilocytosis tells us about membrane integrity and disease processes. The color, hypochromia reflects hemoglobin content. Distribution, are cells evenly dispersed or clumped? Relative numbers, do proportions match physiologic expectations? This is morphology meeting physiology. A CBC gives numbers. A smear explains why those numbers exist. And here's a little histotech reality check. Staining quality, smear preparation, and slide handling directly affect interpretation. Bad smear equals bad information. And yes, technique absolutely matters. Your preparation skills directly influence diagnostic accuracy. You're not just making slides, you're preparing evidence. Okay, this slide represents one of the most important mindset shifts you will make as a laboratory professional. Before we diagnose, before we label, before we panic about blasts or weird-looking cells, we observe first. In histotechnology and hematology, interpretation without observation is how mistakes happen. The microscope does not reward assumptions, it rewards patience. When we approach a blood smear, we are not immediately asking, what disease is this? Instead, we ask structured, observable questions. Are cells present in appropriate numbers? Do they appear mature for what should be circulating? Are proportions balanced? Or do the cells look structurally healthy? Think of this like walking into a room and scanning the environment before forming an opinion. You notice lighting, spacing, organization, the overall pattern, before focusing on individual details. Microscopically, we do the same thing. So at low power or 10x, we look at the overall distribution and smear quality. At intermediate power or 40x, we look at general morphology and population balance. And at 100x or oil immersion, we're looking at cellular detail and diagnostic features. New learners often jump straight to oil immersion because it feels more diagnostic, but experienced laboratorians know diagnosis begins with pattern recognition, and pattern recognition begins at low power. If you skip observation, you risk diagnosing preparation artifact instead of pathology. And yes, we all have seen someone chase a rare abnormal cell that turned out to be stain precipitant. So remember, observation is not the slow step, it is the smart step. Here's a truth every histotechnologist eventually learns. Bad preparation can create fake disease. A poorly made smear can mimic anemia, leukocytosis, platelet disorders, or even malignancy. And the scary part? Under the microscope, artifact can look very convincing. That's why, before evaluating cells, we evaluate the slide itself. A diagnostic blood smear should have a feathered edge. So this is your Goldilocks zone, not too thick, not too thin. Cells should lie in a single layer with minimal overlap. If cells are stacked like pancakes, morphology becomes unreliable. Number two is even cell distribution, right? So cells should gradually thin from thick, which is optimal, and feather edged, right? So uneven spreading causes false anisocytosis, an artificial Rolex, and distorted leukocyte appearance. In other words, technique can manufacture pathology. And number three, poor staining quality. Poor staining changes cytoplasmic color, nuclear detail, and granule visibility. And since hematology relies heavily on subtle color differences, staining problems can completely derail interpretation. Histotechnology connection here. You already understand fixation and staining artifacts in tissue sections. Blood smears follow the same principle. Structure only tells the truth if preparation preserves reality. A useful rule: if the smear looks bad, trust it less than your instincts. Always evaluate slide quality before evaluating the patient. This slide might be the single most important philosophy of this entire course. You cannot recognize abnormal until you deeply understand normal. Pathology is not random chaos. It is deviation from an established baseline. If your mental image of a normal red blood cell is vague, then everything starts to look abnormal. Pattern recognition breaks down and confidence disappears. And honestly, that's where beginners struggle most. Experienced laboratorians don't memorize diseases first, they memorize normal appearance so thoroughly that abnormalities almost announce themselves. Normal red blood cells should be uniform in size, round with central pallor about 1/3 the diameter, smooth margins, even staining. Once your brain locks that pattern in, abnormalities become obvious. Microcytes, they suddenly look tiny. Macrocytes jump out immediately. Target cells have unmistakable architecture. Schistocytes sound off visual alarm bells. This is why week one focuses so heavily on baseline morphology. Think of bone marrow as the training academy and peripheral blood as the active workforce. By the time cells reach circulation, they should look professional, mature, and ready for duty. If immature or bizarre cells show up in peripheral blood, that's like seeing trainees suddenly running hospital operations. Something upstream has gone wrong. So our goal this week is simple but powerful. Build your visual library of normal. Because diagnosis does not begin when you see abnormality. Diagnosis begins when you recognize that something no longer fits the pattern of normal. All right, now we step out of the textbook world and into real clinical practice. Hematology is not just about identifying pretty cells under a microscope. Every smear represents an actual patient, an actual clinical question, and often an early opportunity to catch disease before symptoms become severe. Blood is incredibly sensitive to physiologic change. Because blood cells are constantly produced, circulating, and removed, abnormalities often show up here before structural tissues demonstrate obvious pathology. That's why blood is frequently the first tissue to wave the red flag, sometimes literally. When we evaluate peripheral blood, we're helping clinicians answer questions like, is this anemia due to production failure or destruction? Is the immune system reacting to infection? Are immature cells escaping the marrow? Is there evidence of marrow stress or malignancy? A CBC gives numbers. A smear gives meaning. And this is where laboratory professionals, especially those trained in morphology, become critical members of the diagnostic team. A fun reality check: many major diagnoses begin with someone in the lab saying, this doesn't look right. Observation drives medicine. Now here's where this connects directly to you as histotechnologists. Even though hematology often feels like it belongs to the clinical lab, hematologic disease absolutely crosses into surgical pathology. And you will see it. You may encounter bone marrow biopsies, lymph node excisions, splenic tissue, leukemic or lymphomatous infiltrates in almost any organ. And here's the key point: hematologic disease doesn't stay politely confined to blood. Leukemia and lymphoma frequently infiltrate tissues, meaning the histotech preparing that specimen plays a major role in diagnosis. So fixation quality, section thickness, staining consistency, and antigen preservation directly affect downstream interpretation, especially immunohistochemistry. If sections are thick, crushed, or poorly processed, subtle infiltrants can be missed or misinterpreted. So understanding hematopoiesis and cell maturation helps you recognize why certain cells appear where they shouldn't. You're not just cutting tissue, you're preserving diagnostic information. And honestly, pathologists absolutely notice when slides are prepared by someone who understands disease biology versus someone just following the steps. Let's address a few myths that almost everyone brings into hematology. First, all blood cells look alike. They absolutely do not, but early on they feel like they do. That's normal. Your brain hasn't built pattern recognition yet. Second myth: hematology is memorization. It's actually the opposite. You are not memorizing hundreds of cells, you're learning developmental logic, how cells change over time. Once you understand maturation patterns, identification becomes reasoning instead of guessing. And third myth: I need to know every cell immediately. Nope. Recognition develops gradually through exposure. Your brain builds visual libraries the same way it learns faces: repetition, comparison, and context. Early learners look for labels. Experienced professionals look for patterns. And here's reassurance I always give students. Even seasoned laboratorians occasionally pause and say, let me take another look. That pause isn't weakness, it's professionalism. Let's pull everything together. First, blood is a dynamic tissue. It's constantly renewing itself, which makes it both incredibly informative and incredibly responsive to disease. Second, all blood cells originate from hematopoietic stem cells. That shared origin explains why developmental pathways matter so much. When development goes wrong, morphology tells the story. Third, development follows predictable pathways. Disease often represents interruption, acceleration, or distortion of those pathways. And finally, understanding normal development explains pathology. This is the foundation of everything you'll learn moving forward in hematology and histotechnology alike. If you remember nothing else from week 1, remember this: we don't diagnose abnormal until we truly understand normal. Week 1 is about building that baseline. It will end on a slightly lighter note because hematology can feel overwhelming at first. If someone asks what blood group you are and your answer is red, honestly, you're not alone yet. Right now, everything probably looks similar. Terminology feels new, and there's a lot of information coming at you quickly. That's expected. Learning morphology is like learning a new visual language. At first, you see shapes, then differences, and then patterns. Eventually, you start recognizing disease processes almost instinctively. That transformation doesn't happen overnight. It happens through repeated observation and guided practice. So as we move forward, focus less on perfection and more on exposure. Look, compare, ask questions, look again, because every expert hematology professional started exactly where you are now, staring at a smear, wondering how anyone could tell these cells apart. And I promise, you will get there.